4-year-old boy who is found unconscious on the road. Now, bystanders brought the child to the hospital, and on examination you find a GCS of E2, V2 and M4. Now, what should be your approach in this case? Nobody has seen the event. There are no history. There is nobody to give you right history. Only the bystanders have spotted the child and they have brought the child to the hospital. Now the approach cannot be like in the previous case where we are asking for fever, last meal, abnormal body movements. How would we approach in this case?
The answers in the chat box could be road traffic accidents, any trauma, hypoglycemia, syncope. These are the various answers I have so far. Heat stroke is an answer. ABC with cervical spine stabilization is another answer. Monitor heart rate saturation, cardiac causes. Monitor as per PALS protocol, force. So, varied answers. We go back to Dr. Vikram.
So again, in this case, examination is even more important than the previous case. In previous case, you have attendants who can give you history. Now you have to entirely dependent upon your examination skills. So again, we have to do a complete exposure. And when we saw this child, there was a ligature mark on the neck, right? See, very minute, minor ligature marks, but that was suspicious. And what we immediately do was put on a cervical collar. It is unfortunate that smaller Philadelphia collars are not that readily available, but nonetheless we have to stabilize the cervical spine. So we makeshift kind of arrangement was done, and we make a sort of hard collar for the neck. So that is the message I want to give through this case, that again, the importance of exposure in the examination. You have to look for these signs, especially when the history is not readily available. You have to look for anything which can give you any sort of clue. And then one day later, the parents come with a CCTV footage where we were able to see that child just accidentally strangulate himself in a nearby playing area. So that just confirmed our diagnosis. And even the CT scan proved that there was an odontoid fracture in this patient.
Dr. Vikram, are children more at risk for cervical spine injury?
Yes, they actually do, because children have larger head size, so they have a higher fulcrum of the injury. So that is why they have a higher level of injury. The cervical spine injury is more common, and also because they have more risk of airway compromise because of the smaller size of the airway. They definitely are at more risk for cervical spine injury.
A question now for the students. When should you suspect a spinal injury in a child? So give us some pointers, some clues to suspect spinal injury in children. Waiting for your answers in the chat box. One is already that Dr. Vikram has said that look for any evidence of trauma. A battered baby is an answer. Hypotension, all forelimb weakness is there. Any other weakness below the level, history of drowning, fall from height. Okay, all these can lead to spinal injury. Road traffic accident. Particular specific signs or symptoms where you expect a spinal injury. I'll come back to painful extension and flexion of the neck. Yes, the movements of the neck are severe pain in the neck or the back. Respiratory paralysis, quadriparesis are the other answers. We come back to Dr. Vikram.
Yes, so whenever there is evidence of trauma with ongoing change in the level of consciousness, that is first thing. Any road traffic accident, you should first rule out cervical spine injury. If the patient himself or herself is complaining of severe pain in the neck or back, if there is history of substantial force on the back or head, like in the car injuries, and whenever the patient complaining or you on examination find weakness, numbness, paralysis, lack of control of limbs or lack of bladder bowel movements, or when their body is in odd positioning or twisting of the body is there, twisting of the neck is there, then also you should suspect spinal trauma, cervical spinal trauma in these patients.
Dr. Vikram, what is the role of radiology or imaging in such children who are having a spinal injury?
Right. So in adults, we have quite well-established rules. Like we have Canadian C-spine rule and Nexus, which is National Emergency Access Utilization Study, which have proven to be very beneficial in ruling out cervical spinal injury in adult patients. But unfortunately, we don't have any such things for children. And the reason for that is that in young children, many of the ossification centers may still have not fused. So interpretations become very difficult, whether it is the bone have not fused or there is a dislocation or a fracture. So for till now, we don't have any definite guidelines on the radiology aspect to rule out cervical spine injury. Then there is a term called SCIVORA, which is spinal cord injury without obvious radiological abnormalities. So,
can you repeat that, Dr. Vikram?
Yeah, that is SCIVORA is spinal cord injury without radiological abnormalities. So that is seen to be more common. So that is spinal cord injury. Spinal cord has suffered injury, but without any radiological abnormalities. So that can be a concussion sort of injury, and that is seen to be more common in children. So these are the two things. One, the ossification center is not fused, and then SCIVORA is more common. So radiology is not very reliable tool in these patients when we suspect cervical spine injury.
There is a question from Dr. Reddy, which I also wanted to ask. What about maintaining airway in cervical injury, and can these patients be intubated?
Right. So how do we maintain airway? So if airway needs to be maintained, then intubation needs to be done. So if the patient is not able to maintain his or her airway, if the GCS is falling, if the GCS is below 8, then we have to intubate this patient. But we cannot use the usual maneuvers. Usually what we do is we slightly extend the neck while intubating the patient. We do that chin lift, head tilt maneuver where we do the slight extension of the neck. But because these patients have already cervical spine injury, we cannot extend the neck. So what is recommended in these patients is the jaw lift maneuver, where you keep your fingers behind the mandibles and you just gradually put the jaw without putting any pressure on the cervical spine to make the patency of the airway.
Yeah. So many of the students have written jaw jerk. So remember, this is not jaw, you are not have to do jaw jerk, this is jaw thrust maneuver, which should be used in place of the head tilt and chin lift maneuver. So this is a jaw thrust maneuver, which is the correct terminology used for this maneuver, jaw thrust maneuver. So any query from the residents on this case, cervical spinal injury? It was a brief case, but I think very informative. The role of radiology, how to identify it, and the most important is when should you suspect. So if you have any evidence of trauma, if there is a severe pain in the neck or back, if there is a history of substantial force on the back of the head, if there is any weakness, numbness, paralysis, respiratory paralysis, lack of control of limbs, bladder bowel involvement, or odd position, or somehow you feel the neck is not in the correct place. So always then suspect a cervical neck injury in these cases. We move on to the next case with Dr. Vikram.
Right.
Management. Dr. Vikram, there is a query on management. I think we told about it.
Yeah. So many of the time these patients do not require any surgical treatment. Rather, most of the injuries are dislocation type. So if you put a cervical collar, hard cervical collar for long enough, they spontaneously recovery is there. Many a times, if the injury is substantial, they may need neurosurgical interventions, and then surgery has to be performed.
Thank you.